So I think we can start. First and foremost, I want to say a big thank you. I was a bit upset with the organizers. That's to have fixed, our session at 4. But haven't seen you here. I think I'm excited. At least everyone is not as tired as I am. Yeah. So first, we want to say a big thank you that you are here with us at this time. On the hallway this morning, I was trying to just engage with a few colleagues, and someone just said, our new buzzword now is DPI, 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 DPI. And it was interesting because it's a buzzword to others, while to others is our current implementation reality. Over the past 3 to 4 years, at CRS and at Malaria Consortium as well, we have made a strategic shift in that direction. And as part of what you will be listening to today will be experiences out of, our field work across countries like Nigeria, Congo, Liberia, Togo, etc. And if you have worked in these countries, you know how easy and seamless it is to work in these countries. So we hope that this experience will add a lot of exposition to all of the package that you'll be leaving this conference with. Our key theme is from fragmented campaign tools to reusable digital public infrastructure. We'll be having 2 presentations as part of this session. The first is from our colleagues at Malaria Consortium and eGov, and the second will be from CRS. I think I will just give the presenters a minute to introduce themselves, and I think we can go from there.
Hi, everyone. Welcome and good to have you in this session. My name is Dorcas Essien. I work with Malaria Consortium as the digital health manager, managing all of the digital health implementation, supporting the programs in country. Thank you.
Thank you.
Hi, everyone. My name is Victor Adebayo. I'm the Global Health Supply Chain Advisor for Catholic Relief Services and also the focal point for supply chain digitalization initiatives. Thank you.
Thank you, Victor.
Hi, everyone. My name is Sandra Akura. I work with eGov Global. I'm the program manager covering West Africa, and I'm glad to be here and see all of you here. Thank you.
Excellent. All right, so I think we would start. Have I introduced myself earlier? Okay, I'm Elijah Eku. I'm the Senior Technical Advisor for Digital Health at CRS. All right, so I think we would get into the first presentation from our colleagues at eGov and Malaria Consortium. Doctor.
Okay, thank you and welcome once again. I'll be speaking from Malaria Consortium, talking about our experience moving from fragmented tool to digital public infrastructure. Okay, just to give a brief background of Malaria Consortium, established in 2023, Malaria Consortium is a leading UK registered charity organization dedicated to health and saving lives in communities affected by malaria and other associated health inequalities. We work across Africa and Asia. Okay, so this is just to give Malaria Consortium and the campaign landscape, because what we're talking about today is how we move from just a tool mindset to digital public infrastructure. So specifically, Malaria Consortium Nigeria, we work with Ministry of Health and national program to deliver large-scale campaigns. Our campaigns span multiple and overlapping interventions and operate within 4 to 5 days. For last year, we reached over 25 million children across 25 states. And for this year, our coverage is projected to extend further across 15 states. And this map basically shows our spread across the 15 states that we'll be covering. And down there, you could see the different overlapping interventions. We cover large-scale malaria chemo prevention, vitamin A, ITN, azithromycin, ORS, and the rest. Those are the different campaigns that we cover in Malaria Consortium across the 15 and 14 states we implement. Okay, so moving on, campaign execution challenge. As you can see our scale, we cover over 15, at the moment for this year, we're covering 15 states across the 31 states in Nigeria. And so far, as you could see the spread of the interventions, we've been doing digitization, but as part of that, each of these interventions operates in silos. Each of these campaigns operate in silos. SMC has its platform, ITN, SZM, routine immunization. All of these have been operating in silos, using different systems. What this actually created for us was what you can see here. We had a lot of data fragmentation, duplicate and quality gaps, because of course, each of these systems has its own architectural design and how data is structured and how it is collected. And so it's usually difficult to have a bedside view of everything that is being done at the country level or at the organizational level. So we had weak traceability. You cannot cross-validate implementation across this because of the different fragmented tool that was used. So what we think as part of all of our implementation is campaign digitization should not create additional silos, because obviously we work in public health and it keeps changing. There are new intervention keeps coming, and we cannot continue to create new silo system just because we want to respond to an intervention. Okay, so why does this matter now? The challenge is no longer whether digitization tool can support campaign. As you can see, what we were able to achieve in 2025, reaching the 25 million I talked about is actually verified digital record, right? So that level of scale is already supported by digital tool. So it's not about if technology can support us, large-scale health campaigns, because obviously it's operational intensive, SMC and all of those reach millions of people in very compressed delivery windows. Most of this campaign happened within 4 to 5 days, right? And across different geographies. So the digital opportunity is for us to move from after action to reporting to real-time operational intelligence. So we want to not just use tools, we want to increase speed, quality, efficiency, and ultimately ownership of all of this, because ultimately what we do across all of these states, we work with governments. And so this is, we're no longer thinking about digitization in terms of can it do this or not, but do we have the right operational model to continue to scale across these different interventions? So as part of our thinking, coming from where we came from, so we had a strategic shift from tool to infrastructure. So Malaria Consortium Nigeria journey is best presented as a deliberate transition because most of this campaign and intervention I talked about, they are also differently funded. So but it also sits within a state. Within a state, you can have two types of intervention happening there. So there's also the tendency to assume it's different intervention, it's different funder, therefore I can use whatever it is I want to use. So we moved strategically from then to, we moved from point solution mindset that I can use whatever I want to use. So we have been using digitization, learning from all of this experience where we had limited reuse of data across program, dashboard are always standing on their own depending on the intervention, and high dependence on bespoke tool. We transitioned to a very structured digital approach. And like I said, campaigns keep changing. New public health issues keep coming on, and we cannot continue to create new tools. We want tools that we can continue to reuse across board. So we did a deliberate transition for harmonization to harmonize digital to all our tools across all of our intervention, to scalable workflows across campaigns so we can reuse different workflows instead of recreating them, real-time visibility across during implementation, improve data quality and accountability, and ultimately what this creates for us is the digital public infrastructure operating model. So across all of this intervention, which is more than 5, we have shared registry and services, reusable campaign building blocks. And across all of these states, we're working with government to ensure that they own the process as well. So the shift began in 2024, built on earlier pilot and tools, aligning with what the national and what we want as an organization as well. So from where we are coming from, I've talked about the different tools that we have used. So reframing the solution, which is the digital public infrastructure approach. We had successfully consolidated our tool from the different states, from the different interventions that I talked about, into Digit STM. Is a public, my colleague from, our partner from eGov will talk about this in more detail. But we had transitioned from different instances of tools we usually use across the different intervention by piloting the first use case of this tool, where we did our consolidation of across all of the intervention in 2024. So that was the first use case of using this, and that was for seasonal malaria chemo prevention intervention. That was in KB. Of course, it was government-driven to make sure that we are not introducing something new. And this was the first use case of using digital tool for SMC in that state. And SMC, if I can recall, has been operating there for well over 10 years. And so this was their first use case of introducing a tool for SMC implementation, following the normal software development cycle and ensuring strong stakeholders engagement. The aim first was to, like I said, we have used a lot of tools, but the aim was to test the feasibility of using this tool and using bring your own device as well, and to gain learning to inform future scale up. And the most important part of this is that we were doing this because our thinking had shifted, right? And what we wanted to achieve with this is to consolidate all our effort into this tool to see how we can achieve the idea of the digital public infrastructure for the implementation that we do. So that was the first use case, as I mentioned, and that was in 2024. And for 2025, we have moved from pilot to scale, which was the shift in the way we did our digitization. And so building from the lesson from the pilot, we expanded to 14 states. And these 14 states in 2025, supporting 15 campaign rounds across multiple interventions. Usually, we would do all of these using different tools across the different intervention. But as at 2025, we have moved from using different tools across our implementation, tested a pilot of the Digit STM, and then consolidated all our campaigns into one tool. And from this consolidation, we have reached over 25 million individuals and support more than 54 million treatment. That means the intervention that we give, and the platform has also supported campaigns simultaneously. SMC across 9 states, SMC plus vitamin A, so integrated campaign, SZM, that's azithromycin across 3 states, and all of the beneficiaries there that has been reached. So we had moved from different tools to a pilot of our consolidation thinking into scale. And all of those different interventions now, SMC VAS, SZM, ITN, all of them operated under this one platform, sharing resources, sharing registry, and reusing data across our intervention. So just just to quickly talk about the result, as part of all of this consolidation, cost efficiency at scale happened. So strategic consolidation under this platform, Digit ATM, reduced annual costs from 150 from 2023 to $30,000 in 2025. So I might just want to talk about that very briefly. Most of those tools that the different intervention use, most of them were also proprietary. They were also subscription-based. So it was also capital intensive, managing them across the different intervention. Another thing that also quickly reduced that cost was there was very high dependence on external consultants, right, to help to scale this tool. And because of that, you also have to pay. But what we did is that we integrated digitization into the normal health campaign workflow, right? Because as a part of normal health campaign workflow, you know you have to do micro planning, you have to do training and all of that. But oftentimes digitization sits outside of that, right? So we get consultants that do training, separate training days and all of that. But we remove that and integrate digitization into the main campaign implementation, leveraging on the government implementers as part of the routine health system. So we do not need to pay for a lot of other things that we do. So the cost there is majorly infrastructure costs, which is the main cost driver that gave us that. There are other parameters there, but I just needed to highlight that. Another very important part is the continuity of childcare. Because of this consolidation, we can track intervention. We can track children across multiple intervention. Because now there are shared resources, shared unique ID. So I just give a use case there of in Kebbi State. In Kebbi State, we implemented 2 types of intervention. And usually we would use different 2 types of tools. And you are using the same geographic boundary. And so at that point, you will not be able to triangulate or be able to trace which child collected. And all of them, some fall within the same under 5 population. So you will not know, we don't have visibility to this child collected intervention and also collected the other intervention. So based on this, we're able to track children across intervention. And you can see we had 95% overlap across the 14 LGAs in Kebbi State. So that means we could trace the child that have collected SMC and has also collected azithromycin. And we could also see the gap of those that did not collect that intervention. So that the consolidation also really helped us for continuity of childcare. Data reuse as well. We achieved over 80% data reuse across repeated campaign cycles in states such as what is there, Kogi and Oyo. So data reuse means that I could share our registry or we could share data across the different intervention, and we reached that level of percentage in data use. Improved target accuracy. So usually the same, like I said, the same intervention, 2 different interventions can happen within the same state, and they can have multiple percentage coverage, but this you can verify. Effective data use across different administration. So we are not just using the data for immediate, we use it for post-campaign, post-surveys, and a lot of other things, and evidence-based structure culture as well. Based on this consolidated data, we could see low-performing LGA across the different intervention, coverage gap in real time, and corrective action during our intervention. So as part of this, all of this consolidation happened as part of the platform that we use. So I would like my a product partner from eGov to speak more to the tool, and then I'll come back. Thank you.
Thank you, Dorcas. Okay, so taking up from where Dorcas stopped, I know you've heard about digits, like she said, so just progressing from that. What is digits? Digits is infrastructure for governance and inclusive transformation. It's an open source shared digital infrastructure built on shared services and shared data registries. As you can see there, we work with multiple sectors on one building block. So what it is Digit functions as shared services, shared data registries, and it also has data exchanges, which is interoperable. That is what Digit offers you. I will just move forward. It supports efficiency, transparency, and inclusive public service delivery. So from siloed approach to DPI approach with Digits, you would usually see your traditional approach, which has fragmented tools that are utilized to carry out different interventions like, polio, malaria program, or measles. But all these are siloed systems. What does Digit offer you? You have the DPI approach, which is digital public infrastructure approach, where all these services can be built on one model, one building block, and shared across the different services where you work. That means we have your planning, your registration, your field ops or dashboards all flowing on a unified interface. You do not need to have it fragmented or in silos. All of it falls under DPIs. Now, it is a single source of data that is reused across programs, and we have improved data availability and observability that aids data-driven decision-making. That means you can have all the states, like she had mentioned, 14 states were deployed on one central instance, whereby feeding multiple tenants. What does that mean? Each state had to feed from one infrastructure without needing to have separate instances across these 14 states. So we had the DPI exemplified across the MC campaigns, built on one instance with multiple tenants. And then we had faster innovations because we were building off from what already exists. We didn't need to start from the scratch. Now, I would just move, and then one thing that this brought forward was country ownership. That means the country could own the process. You do not need the team to be the ones in the forefront of handling this. You take this, you build the way you want to build because it's an open source tool. You don't need any licensing cost for this. It is all for you, and the codes are always available for you to access whatever you have built. Moving forward, what can countries do? Countries can actually drive a self-sustained digital transformation in public health using DigitATM as a starting point. As you can see, currently you would have multiple siloed systems. But what does DPI bring to the table? It brings you a unified system. That means you can have your systems integrated on one infrastructure, and then you move forward to ensuring that these integrated systems have your shared registries and your shared systems. So whatever you have built for A can just be picked up and reused for B. You do not need to start from the scratch. And then it increases country ownership and reduces costs. Like Dorcas had shared previously, you would see that there was a cost reduction when she had mentioned as one of the results that they had experienced in Nigeria. On this, you move to public health platforms where all your services can actually be on one, on the DPI. That means all services which enables improved data analysis can be done on one shared infrastructure. And then country-owned platform with application development distributed across the enabled partners. One basic thing that Digit does is to ensure that the capacity of partners are built. That means there is little or no reliance on the eGov team, because like our partner MC has been able to pick up some of the activities that usually we would take up, things like help desk supports, generation of reports and all that. That is done by the MC team, requiring little or no involvement from the eGov team. And then you see that once this translates from public health platform, phase 3 is to ensure that governments can now own the system and innovate on the solutions they have built before now. Now, this is just, I think we can discuss further on this since we're pressed for time. But this is just the progression of digits as a DPI. So I will just speak on the cost efficiency bit. Like Dorcas had mentioned earlier, when we deployed in Kebbi State, we had deployed at a cost of 166.67 cost per LGA because there were 21 LGAs in Kebbi State. Now, this is just the cost of infrastructure. Like I said, there is no payment to EGOV for whatsoever. So all you need to do was the infrastructure cost. And this was going at 166.67 for just 1 month. But now, when we moved forward and scaled to 14 states, this is the cost we had covered for 999 LGAs. It was $98.38 across 7 months instead of 1 month, which was 166. That's to tell you that when you build off on DPI, digit as a DPI, you have reduced costs. That means you're not spending on licensing. All you're just concerned about is your infrastructure, which feeds across all your intervention. You're not concerned about having multiple instances for multiple interventions. So what this means is cost efficiency per LGA was reduced. The key takeaway is scaling up the coverage with digits leads to cost efficiency, enabling greater impact for lower cost per unit. So it brings out more reach, lower cost, and greater impact. So this is just to give you the brief on how we built once and the manpower that was required from that's the workload from when we started the pilot and how it has reduced down to the deployments we had in for ITN in 2025. So I'll just pass it over to Dorcas to take it up from here.
Thank you. So basically, thank you, Sandra. So like she said, I think the whole idea of DPI is consolidation and reusing infrastructure rather than creating silos and all of that. So I'll just give a key lessons learned. So in all of this, because I had mentioned that Malaria Consortium majorly works with government, and across these 14 states, there was strong government leadership. And because we are dealing with data, which belong to the government ultimately, because we collect client level record, sustainable, whatever we're talking about now has to be driven by government. So a key lesson for our success was that it was government-led, strong government involvement. So they own the process, and that allowed them to own the data and use of data. Another important part of it is the training, right? And so, like she rightly mentioned, all of this would make no sense if the people that are supposed to use it are not empowered to use it. And so we make sure that we realize that high quality training is very critical in this process. And another important part is strengthening in-country technical capacity, state-owned level command centers. So I think I'd mentioned this in my previous slide. We gave this to the states. They own the process. They manage the process. Everything about what we are doing, they're the one that lead the process. So government leadership, training, and technical preparedness is another very important thing. With all of these things, deploying digit, pre-testing, testing device, data validation, continuous feedback is a critical aspect of this. And another thing, lastly, is infrastructure. As we mentioned, initial digitization costs are capital intensive, but as you consolidate and scale up, the price begins to reduce at scale. So I just quickly running through our vision. So we've talked about this consolidation, and it has allowed us to track children. So advancing integrated child level tracking to support continuity of care is what we want, because operating in silos does not allow us to see everything happening across the intervention. So advancing that state level domestication, allowing the state to continue to lead the process, harmonizing. So we're not going to a state and creating silo. We're making sure that we are speaking the same thing, understanding why we should consolidate and leverage digital public infrastructure, and expanding digitization across what we do. So what we are calling everyone here to do is for us to achieve this as people in Nigeria and any other place, is for us to come together to co-design, align campaigns with our country priority, co-invest in it. We're talking about infrastructure, right? Yeah, it might seem initially it's not too much. Of course, at the beginning it's too much, but as we consolidate, it will reduce. Co-govern, let's support data governance, and let us co-learn. So that means how we have gotten here, let's leverage this lesson across our implementation. Thank you. So I'll call on my other colleague. Thank you.
Okay. Thank you very much, Dorcas. Since our time is fast spent, I think it's best for us to just move to the next presentation, and then we can take questions at the end of the day. Thank you so much.
Okay. Okay. I think while we wait for this, like, okay, right, it's right there. All right. So, as the presenters have mentioned earlier, I mean, Digit HCM is a digital public infrastructure and has been used in multiple interventions. So what I'll be doing here with my colleague is to really deep dive into how do we ensure that we have accountability in health campaigns. And the essence of this is that from over the years, we've seen that in mass campaigns, commodities, it's usually like the largest portion of every investment in most mass campaigns. And our experience has shown that for ITNs, we need to rethink how we do mass campaigns because we continue to face issues of accountability and erosion of donor trust. So I will go to, okay, yeah, so the presenters will be myself and Elijah. Our outline is taking you through the journey of CRS and health campaigns, why we want to solve the issue of accountability, the innovation we put in place with GS1 standards, the challenges, of course, every intervention will come with attendant challenges, and the benefits we realized, and then we'll give recommendations for everyone. Okay. All right. So I will take us through a very short journey, not as far as Kenya to your from where you came from. So basically, health campaigns, like I mentioned, CRS have done mass campaigns in a lot of countries, but I will speak to Nigeria as a case study, at least in more than 6 countries where we have done mass campaigns. In Nigeria alone, as you can see, over 220 million bed nets have been distributed. And why are we doing this? To protect children, to protect adults, and reduce malaria burden. And this has also covered 83 million children that are under 5 from seasonal malaria chemoprevention. And we started digitizing mass campaigns using proprietary tools since 2014. And currently, we are in 5 countries where we are scaling digital public infrastructure. Oh, is the slide? Okay. All right. Okay. All right. So apologies for that. I guess ICT4D is playing on us here. So so talking about why accountability matters, I think I did mention earlier that the cost driver, the major cost driver for mass campaign is the commodities. So inevitably, it's very important that we need to ensure reconciliation of those commodities and ensure that we can account for it. But what we were doing before, of course, there's always room for improvement, was to track the bed nets with the net cards. So as you can see, we have a net card that is showing that a beneficiary is entitled to 1 net. So while we were doing that, I will call that a proxy reconciliation because we were using net cards to account for net rather than using net to account for net. So accounting for the net is tracking the net itself and not tracking the the net card. So this was what we were doing before. And as you can see, we also encountered the OIG, which is the Office of Inspector General of the Global Fund, identified a major issue from one of the implementing country where we were doing mass campaign as at then, where over 117,000 bed nets were diverted, leading to more than 425,000 USD unaccounted for. And we were also having challenges of nets being distributed more than the net cut. We had challenges of reconciliation coming very much as more than 3 weeks after mass campaigns, and of course, issues of costs, because we needed to print those net cards, right? And in some instances, we had to even import them. So we have huge logistics costs as a result of net card. And you can see where we have reconciliation is always messy. This is a reconciliation going on in one of our implementing states, and you can see one person that is even having to police the system to be sure that they can account for each piece of net. Now, we move to rethinking how to do this and come up with innovative ideas. We move to the global standard one technology. And what is global standard technology? This is a technology that, as many of us might have encountered when you go to the grocery store, you buy a product, you see that they scan it, and then before you are issued to it. So before it is issued to you, rather. So we, because of the numerous recommendations that we've had to have, we recommended, even to the donor, the need to begin to rethink accountability using GS1. And these are the products or data carriers that we were tracking for each net. We have the serial shipping container code. These codes, you will see that on the, that stands for SSCC. These codes represents a unique identifier that is attached to a logistics unit. In this case, a bed net, a bill of bed nets. We also have the GTIN. GTIN is used to track the trade item, which is the bed net itself. We have the global location number that helps us to know where those nets are located. We have batch or lot number. This is very important, especially when scaling GS1 to pharmaceuticals, where you have to do product recall, because you can track the batch that has went to a particular place. And also the production number. And more importantly, is the unique product serial number. So this serial number is used to track, is a unique identifier to track every piece of bed nets. And it's valid for at least 5 years. Bed nets are always valid for 3 years in reusable. So you have these codes embedded on each piece of net, and they are linked. So you have the bill, that's the bill sticker, and then you have the ITN sticker. So when you track the bill, you can use that to know where the bills are and where they have traveled to. And then when you track the ITNs, you can link that to individuals, every beneficiaries, and you can account for the nets as opposed to accounting for net cards. So having done all of this with all the brainstorming, we have to think of, okay, we've come up with all this strategy. So what tool are we going to use to ensure that we can track and trace the ITNs? And that brings us to the use of the DPI approach, which my colleague Elijah will be talking about. Thank you.
All right. Thank you very much, Victor. Maybe before I move into the tool, I just want to say a few things about even our work and how we actually got here. So as you can see, looking at this voucher, right? I'm not sure if this light is working. Okay. All right. In 2017, we introduced our digitalization. Yes, I got it. And then we introduced this high-end net card. It is very beautiful. It has a QR code. It has invisible print, etc., etc., etc. And actually, we had thought that we had done a very good job ensuring that accountability can actually be achieved, because at the point of scanning the net cards, etc. But we had the biggest nightmare of Victor's team. After every campaign, and bits and pieces of net cannot be reconciled. It's like 2 pieces here and 3 pieces here. So it implies that the vouchers that we have counted is not the same as the nets that have been distributed. And then, all of these bits and pieces everywhere. And we kept asking, how do we solve this problem eventually? And one critical thought at that time was, our distribution is ITNs. And what we want to track are ITNs. Why are we using vouchers, introducing another layer of complexities? And we had to kind of decode that, and that was where all of the ideas of having a unique identifier in the net was actually now better. Unfortunately, in the context of all, all of the tools that we were using at the time, to rebuild this new model and new thinking, of integrating these JS1 standard codes on the net would have been very, very expensive. And thanks to our donors at the Gates Foundation, who now enabled a critical partnership with the Eagle Foundation, where we had to kind of sit down with them to kind of, identify this problem and, establish that partnership to see how we could reconstruct our use of JS1 standards on the nets as our new accountability mechanism. And what this now did for us is it completely eliminated our use of the proxies, all of the net cards that we're using, et cetera, et cetera. Now, in case you don't know, the context of producing these net cards, it goes through an entire procurement process, getting vendors, pulling out bids, et cetera, et cetera. And this takes a lot of time, a lot of money, et cetera. We did spend, a lot of time in the context of producing them and having them being transported, and then issuing them separately in the household. Now, it comes with a process of reconciliating everything that you have distributed in the household. So, all of this thinking, it was really a very, very tough and difficult one. Now, our current process is all of the JS1 standard codes are now embedded in the nets. And all we do is, at the point of receiving these nets in country, it is stored in the warehouses, and the distribution team just head to the household, and upon enrolling the household, they obviously just scan the nets and issue them out. Now, it was an exciting outcome at the time because we had a lot of cost savings, which I will be going into that. However, we had a few issues and challenges. So first, in the context of handling the bills, a few of the codes will, obviously go bad in the context of dragging and packing, etc. Also, at the point of manufacturing, we had some QR codes, obviously that were not printed well. And we then have, we still do have the issue of, of non-adherence to all of the processes of scanning even this voucher. Yes, it is deeply dependent on how much we train people, etc. But I think in the context of DPIs, as the same platform is actually being kind of reused over time, all of our community health workers are now able to improve their capacities on how they use this. Also, we have a couple of human errors in scanning, and mis-scanning, etc. Also, we have issues with devices, especially if it is a BYOD case where, obviously you have phones with bad cameras, etc. However, looking at these challenges, they were nowhere near all of the benefits that we had. A good example is it's a nightmare to print and command these vouchers. It takes at least 6 to 8 months enabling this, etc., etc. Also, we now have an integrated accountability workflow where it is the net itself that you are tracking in the household. I don't know if a couple of you have seen all of our beautiful maps where we have like all of the redemption points and so on. All of those redemption points were actually indications, of the transactions that had happened. But now you can tell the specific place where that specific net with that unique ID is located. And after like 1 or 2 years, if we still have like surveys to do, etc., to track all of these nets, we can always go back and track that, which is really exciting. I would spare us the time of going through this. Let me just go quickly into our cost analysis as well. In 2019, we spent as much as $1 million just on vouchers. Now, as I speak to you, across our implementation, this cost is currently zero. In fact, we did have a country engagement where they are still kind of pushing us to use vouchers, and we're like, hey, no, we need to really just rethink how we do this. So imagine in the implementation context where we are right now, and we are able to save as much as $1 million in our intervention, it is really huge. Also, and finally, we have some key, I'll call them learnings, but not just learnings. I'll call them experiences that we are still also building. So first, we need to have that mindset shift as countries. As I'm speaking to you right now, we still have some countries in this room who are still insisting to use vouchers. Even with all of the evidences that we are trying to bring to say, okay, our colleagues at the Global Fund has done so well, ensuring that all of the recommendations are being adapted into all the production of the net, and it keeps improving. However, if we don't create room to ensure that all of these lessons are being improved on, then obviously it's the same cycle that will be repeated. Also, before implementing this, it's important to discuss with your supplier of the health commodity. If it's an ITN, etc., it's good to discuss with them, understand all of the protocols and all of the sequencing in the codes to ensure that as you are configuring your system, all of that configuration can match with what you already have on the nets in production. Also, make sure there is adequate testing prior to your deployment. I think it's one of the, if it's working on just 1-2 bales of net and then we just assume that everything is okay. No, I think it's important to really test and be sure that all of the metrics for testing are established as part of our work. Now, training is very tricky. It's tricky because after training people and there's an excitement in the hall, etc., it's very, very different from the reality that they go to the field and they are faced with. So it is good that as part of our trainings, we also include a bit of real life scenarios to ensure that the learnings are actually being put into practice. So in some countries now, they're kind of recommending that we have things like pre-testing, ensuring that all of these are well, experienced and prior to deployment, especially because you are training people who have been used to a certain way of doing things for more than 15, 12 years. So, ensuring that all of that change management process is really well thought through is very, very important. Thank you so much for listening. And I think we'll call up our colleagues now for questions, please. Do we have questions, by the way? Oh, brilliant. No questions? Okay, 1. Anyone else? 2. Anyone else? 3. I think we can take this first 3 and then we'll come back.
Thanks a lot for the comprehensive presentation. I'm just curious to understand, despite the close to $1 million savings, what is the reasoning behind willing to still push you were talking about some people who still wanted to implement those cards, like the physical one. What was the reasoning behind?
I think it's a simple answer to that is adapting to change. Every other thing is within that. And I hope you understand what I mean. Yeah. Second question.
My question relates to the functionality for the Digit platform. So for most of us who work in the community setting, especially for campaigns, users need to know the specific target they're supposed to reach. For example, for under 5, if you have a population, if I've registered all the households in my village, and I have a population of around 1,000, as a user, a community care worker, I need to be aware of that population. So within the Digit platform, are we able to calculate that and make sure that that figure has been shared downwards to the users so that they can be able to provide the intervention and be able to track their progress towards the target? Thank you.
Let me speak to it. Okay, so I'll just speak to it, and my colleague from eGov can speak to it as well. I think part of our implementation process, the whole campaign activity. So there's the pre-campaign planning and all of that, and part of it is the micro planning, right? And so what we do in the micro planning is, of course, we establish the boundaries we are going to work, the coverage based on the boundary, and then the target population to the lowest level, right? So that means from the community, right? We know how many households needs to be covered within that community, and upward from community down up to the state level. All of them have different targets as well. And also, so this micro plan is integrated into the app as well. This is what feed what target is expected, because there are indicators that we monitor as well. So there is the denominator, what is the population you're supposed to cover. So all of that is available even at the user end, at the user itself, within covering a certain community, because we know the population of that community. We also know what a particular user is supposed to cover. So as part of our micro plan updates, as the base of the application setup, all of those information is available across the different level as well. So yeah.
Thank you, Dorcas. Just to add on that, on the user interface, you would always see the daily targets for every user attached to the user. So once you have crossed that bar, you can either stop work or continue work, but there is a there's a progress bar for the targets for each of those users. And like she rightly said, the microplan is pre-ingested to mark up a user to the target that they are expected to cover for the intervention. Over.
Yeah, thank you so much. So such an insightful session. My question is also around digits. So the first one is you mentioned that there was an instance of 14 states sharing one instance of a digit server that was deployed. I want to ask, how did you manage data sharing and privacy among those states? And sorry, there's also this question I want to ask about the digit stack. Like, how do you keep it together in terms of update and skill gap?
Sorry, can you take the last question
The
again?
last question, the digit stack, how do you keep it together in terms of updates? I mean, in terms of updates, yes, in terms of update and skill gap.
Okay, I'll take the first question and my colleague will take the second question. So we utilize the central instance, and like I said, you have multiple tenants. Multiple tenants gives you privacy. That means we can have shared infrastructure but not have access to each other's data. So each tenant was separate but existing on one infrastructure, one instance. So I think I'll.
Actually, we have a webinar every quarterly release cycles and also webinars. So also all our documentation, release notes, artifacts, source code, everything is open source because it's built on open source. So there'll be like webinar announcements on the partner groups, LinkedIn and all. So you can subscribe and you'll be able to receive the release notes and updates and everything.
Thank you.
For your time and for participating in this session. For more information on this, I think you can always just check on the CRS website and the eGov and Malaria Consortium as well. They do have website, and of course you can find information on how to contact our speakers. Thank you very much.